introduce now Mike Kiernan. He's a colleague from Tufts. There he is, Michael. You can't miss Michael. And he is going to be talking about checkpoint inhibitor myocarditis and shock. Does immunotherapy work at all? Dr. Kiernan.
Great, thank you, Eddie. I also want to just take a moment to congratulate Marwan Jumian and the team at Memorial Hermann and Texas Health here in Houston for another terrific program. It's been fun to watch how rapidly this important meeting has grown, to have these targeted conversations, which are so experienced, to learn from each other, shared experiences for the management of patients with shock. So with that, I have no disclosures, with the exception to say that I am not a cardio-onc expert. We don't have a huge cancer program at Tufts. We certainly have a large shock program, but I personally only taken care of a few of these patients. But I will try to share with you what I've learned over the last few weeks preparing for this presentation. So to begin, what are immune checkpoints? So immune checkpoints are inhibitory receptors on T cells that, when bound to ligands, turn off the cellular immune response. So essentially, they're to allow self-tolerance and to tamper the severity and duration of immune response to prevent diffuse tissue injury. And so tumor cells can target these through different ligands and essentially turn off the immune response to evade destruction. And so by using monoclonal antibodies, or what are called immune checkpoint inhibitors, we can block that binding to these ligands, therefore turning the immune cellular response back on, allowing destruction of tumors. But it is somewhat of a non-specific response, and we can see diffuse inflammation and what we call inflammatory-related adverse events across multi-organ systems. And we're here today to talk about, of course, checkpoint inhibitor myocarditis. That occurs in about 1% to 2% of patients treated with these agents. The onset is about a month on average after the dose of the first therapy, and is most common in patients who received combination therapy. Mortality, case fatality rates are quite high and reported to be on average 40% to 50%. So this, we're short on time, but the good news and the bad news is there's actually not a lot of ground to cover, unfortunately. So this is one of the largest series that I was able to find, and it really, this one slide says it all. So it looks at lots of different targets and different strategies in terms of immune regulation using IVIG, plasmapheresis, T-cell inhibitor therapies, IL-6 receptor antagonists, et cetera. But the problem is we're really driven by small single center case reports and case series. And the spoiler alert is, at the end of this, we really don't know which of these therapies are most effective. And that's true really for how we approach treating things like antibody-mediated rejection in the world of heart transplantation as well. We're really limited with the data as it relates to how effective some of these immunotherapies are. But one comment as it relates to thinking about plasma exchange or plasmapheresis. So these are monoclonal antibodies. They have long half-lives for on average of 20 days or more. So the thought is, and there are some data that we can start early with pheresis to pherese off these proteins to limit ongoing immune activation and destruction. So, but what did we learn from this compilation of 28 single cases at a center in France that was supplemented by some cases from the literature? Well, not surprising, we don't know which of these therapies in isolation is most effective, and the waters are always muddied because we're typically throwing the kitchen sink at patients. We're rarely, because these patients get sick so quickly, we often do multiple things at once, so it's hard to tease out the individual benefit of a single agent. But importantly, what was shown is that infliximab, a TNF-alpha inhibitor, that we know, of course, from treating autoimmune diseases, is contraindication in patients with symptomatic heart failure. So it wasn't surprising, while these are observational data, to see infliximab was associated with increased risk of cardiovascular death. So I'd say the next two slides are the most important, and that's what what's been observed. Again, observational data with use of steroids. And that's the question of what dose and what's the timing. Do they matter? So it does appear that timing of initiation is very important. So this is looking at early initiation after patients present within 24 hours. And you could see 93% freedom from major adverse cardiovascular events compared to delayed administration, defined as after 3 days or 72 hours, where only 15% of patients are free of MACE. So we really need to give early, and we need to give high. So does dose matter? So the top line is high dose, defined as greater than 500 milligrams of methylprednisolone. And you can see on the right there, actually, the event rate. So 22% of patients in the high-dose arm had a MACE event compared to the low-dose arm, defined as less than 60 milligrams of salumedrol, and those patients had event rates of 62%. So you really need to give high and give early, but which of these is most important? So the top two lines here are the timing of administration. So you can see very little separation as long as patients receive steroids early. Where dosing is more important is if they're given late. So you can see the bottom, the red lines, that the high dose has significant survival, it appears, compared to lower dose, but yet giving high dose late doesn't mitigate the negative impact of delayed administration. So again, I think the one take-home message is give high and early, and high dose typically means 1 gram of salumedrol for 3 days, followed by a steroid taper. So really, we have just 4 case reports to kind of round this out, and these are the studies that are reported in the European and US guidelines for management of ICI-associated myocarditis, and the first is looking at T-cell depleting therapy, so anti-thymocyte globulin, so ATGAM or ATG in a patient who had glioblastoma presenting with myocarditis, reduced EF, was treated with salumedrol as well as infliximab, and then on day 8 had progressive VT, complete heart block and shock. This histopathology is not from this case, but it is to remind us that the histopathologic lesion of ICI myocarditis is very similar to what we see in the transplanted organ with acute cellular rejection. So in fact, the therapies we use to target this are those that transplant cardiologists are very familiar with, but giving ATGAM in this situation and then titrating over 5 days to CD3 levels led to gradual resolution and improvement of myocarditis in this case. And then importantly, baseline immunosuppression was continued and maintained and really tapered over about a 3-month period, including mycophenolate and prednisolone. So almatuzumab for ICI myocarditis, so this is Campath. So what is Campath? It's a monoclonal antibody against CD52 that's expressed on mature lymphocytes, so both B cells and T cells. So similarly, a case of melanoma. And really, these drugs have revolutionized cancer, treating many malignancies that 10 years ago were untreatable, but does have this potential side effect, fatal side effect in a small proportion of patients. But in this setting, again, this patient was refractory to high-dose steroids, also MMF, plasmapheresis, and rituximab, and had a long course of therapy. So it wasn't until day 18 that they developed refractory VT, worsening hemodynamic instability and shock, and they were given a single dose of cytolytic induction therapy with Campath, and that led to pretty rapid resolution of the symptoms. So we have some good biologic plausibility here as it relates to what we know about treating other malignancies. Campath is used for some B-cell lymphoma as well as T-cell diseases, and seem to improve the clinical status in this patient. Abatacept, some people may be familiar with belatacept, but it's a drug that's used for cellular rejection prophylaxis in kidney transplants, but it's an analog. It blocks co-stimulation, so activation of T cells by antigen-presenting cells through co-stimulatory blockade. Likewise, in a patient who, after 17 days refractory to steroids, MMF, and plasmapheresis, had worsening symptoms, we see that after initiation. So these are biomarkers. So the troponin levels initially rose, stayed elevated, and then eventually down titrated over time. And the last drug that we have is tocilizumab. People may be more familiar with it since the COVID pandemic. It's an IL-6 inhibitor. IL-6 signaling drives T-cell survival, proliferation, and differentiation. And it was used likewise in a very similar case in a patient. This is a little bit cleaner. This patient just received methylprednisolone, but still had rising troponin after over a week of high-dose steroids, and then was given toci. And after 2 doses of toci, we see a down titration of these biomarkers. I'm going to skip this slide just for the sake of time, but really, the message here is you need to have a high level of suspicion. Patients need to be admitted in cardiac telemetry units, low threshold to put them in the intensive care unit. We don't want to be fooled by a normal echocardiogram, because about half of patients, their EF is normal on presentation, even in cases of fulminant myocarditis. But they need to be treated high-dose early steroids. You can monitor them, but I would have a low threshold even in stable patients to think about second-line immunosuppression, things such as mycophenolate or calcineurin inhibitors, and certainly certainly if they're not improving, then you rapidly need to escalate to second-line therapy. And if they're unstable on presentation, then they should immediately receive second-line therapy, likely driven by whatever drugs that you're most comfortable with and familiar with at your own institution. So thank you.
Excellent presentation, Steve and Michael. And I have one question. So obviously, so I'm MD Anderson, so we have a lot of patients with ICI myocarditis, and we found useful actually in the initial phase, and we try to understand the severity of the disease, doing endomyocardial biopsies and see the degree of necrosis on the slides in acute phase, and that kind of triggered the intensity of the treatments we did initially. Also added another interesting idea about what's called permissive toxicity, because we try to induce this inflammation, we're going to have some myocarditis, and the extent of how much myocarditis can we tolerate without having worsening of outcomes and symptoms, which also is a very important concept. And we found that troponin is a good biomarker based on the levels of biomarkers we have in initial phase, how much and how aggressive we are in treatment. But that being said, is we do exactly what you showed nicely in the slides, high-dose steroids really early. Most of the patients will get plasmapheresis in the initial phases. And then the third drug we reach to right now is abatacept. So that's kind of our algorithm right now. And Tom Nealon has a study we're part of with Mass General about using abatacept in the secure setting.
Great, yeah, thank you for sharing that. Yeah, I think it is important. One thing that I learned is that, so I agree, but one thing we don't want, and I would biopsy all these patients when they're coming in to help guide that, but I don't think you should wait for the biopsy results before treating. But then if the biopsy comes back, that may push your hand, if they're stable, to escalating therapy more rapidly. But as soon as you see abnormal biomarkers, abnormal ECG or symptoms, they need to be treated while getting the echo and waiting for the additional workup.
Again, we have different cutoffs for treating them, and again, we do not treat all cardiac biomarkers for sure.
Okay, great.
And so we have usually for high-sensitivity troponin, usually above 500. We get nervous between 250, 500. We're watching them a little bit. Below 250, we do not treat them. We watch them, and we expect, we watch them.
Can I just ask with your experience with that? So, but it seems like these patients, once they're in the hospital, these are not patients you send home. I mean, they're usually going to be in the hospital for weeks, a month or more, as you're down de-escalating some of these therapies to make sure there's not re-escalation of inflammation.
And what is very humbling to us, we had patients with complete heart blocks, so high-degree AV conduction abnormalities with barely abnormal cardiac biomarkers, which is very, very interesting how ICIs can target certain toxicities and not others, which is very, very humbling.
Thank you.
Do you want to comment about the biopsy question? This is getting to a broader question of myocarditis and timing of biopsy. So first of all, it's great to see you in Houston and not in the CCU where we normally hang out. So maybe I can hang out afterwards. But this debate comes up quite a bit about timing of biopsy, patients on MCS, fully anticoagulated, VA ECMO initiation. Do we biopsy before or after VA ECMO? So I was wondering if you want to just give your thoughts on that, and then maybe we can ask also the audience how many people are biopsying on ECMO, or if there's some questions about this discussion about biopsy timing.
Yeah, I mean, I think it's, in terms of if they're not on MCS, it's easy. I think they should all be biopsied. The harder question is as it relates to biopsying once they're anticoagulated on ECMO and the risk, or do you just treat empirically? So for other forms of myocarditis, we, as you know, we feel strongly that we need a tissue diagnosis prior to subjecting patients to the risk of T-cell depleting therapy. In this question, I don't know. If we know someone's, it'd be interesting to hear the panel's response that if we have a high suspicion, given that they've been exposed to immune checkpoint inhibitors, do we need the biopsy if they're on ECMO versus I'd be inclined at that point, feeling confident enough just to move forward with T-cell depleting therapy or abatacept, whatever your protocol is going to be, without tissue, given the risk of biopsy.
Yeah.
Steve, do you want to answer that?
So that's my question. If we know what's going on,
Yeah.
and really sick on ECMO, is the biopsy?
Yeah,
how's
in
the
this
biopsy?
case, I think
they're really sick
no.
no matter
So
what the
it's
biopsy shows.
Right, so it's the difference is this giant cell or eosinophilic
Yeah.
myocarditis versus lymphocytic. If we know they have cancer, they receive combination ICI therapy, I think you could probably just treat without exposing them to that risk.
So my question, so what?
Where you're actually putting in the device, right? If you're already in the cath lab, right, and that's where you're cannulating, you can easily just do a biopsy at the same time. It really just depends.
Yeah, I'm sort of representing the interventional community here, where we get asked to do
Yeah,
biopsies, before initiating ECMO, and And it's always a really important team discussion, as we always have multidisciplinary discussions. But, subjecting the patient to the risk of biopsy, there's now emerging data. There's a nice paper in Circ Heart Failure about biopsying on ECMO, and, actually not an inconsequential complication rate, around 20%. So I think it's a really important question for the field. We need more data, because right now it's still very much consensus opinion.
So I'm interventional as well. So the question that we have, I agree with you. So that's why we're getting into this story. So there's 3 steps to it. One of them is we have limited understanding of the toxicity as of now. And I think pathology brings value.
Right.
So in this initial settings, we set all the biomarkers. You can see that we're checking CD3, CD68. Will this in the long run have prognostic value? Will these patients with certain profile be more likely to die, to have cardiac arrest, more complications down the road? So we do not know. So we have we have probably the largest database. We have 80 biopsies, 80 biopsies compared to the transplant database and everything. We have thousands, and we should learn more about that. So that's part of it. The second one is we have the concomitant, like complete heart block, high-grade AV blocks in a patient with extreme frailty of the myocardium. So probably the largest amount of complication we had were on ICM myocarditis, doing biopsies. So we did not have biopsies, complication with amyloids. We did not have complication with anything else but anthracyclines, but we got more complication with ICM myocarditis. So there's a degree of myocardial frailty in the procedure. We do not feel the wall, which is really very, very intriguing to all of us. That's why can't we feel the wall when we feel the walls in all the other procedures? So I think it's very, very challenging, the procedure itself. That being said, we believe it brings value because the amount of necrosis, we have like great stage. We actually have a nice staging we wrote, and it's published in Heart Failure Journal in Europe. Basically, we staged the 1A, 1B, and 2, and based on that, we decided how much we escalate the treatments, and that's a prognostic value as well.
We'll just take a question from our
Also,
audience.
there's no correlation between MRI and biopsy, which is very, very intriguing as well, and where it comes into play what you said about when we do the biopsy. Is it too early? Is it too late? Is it MRI too early? Is it too late to see inflammation? And how early we
Someone on
act
ECMO.
on this. Yes.
And then are you serial MRIing?
We do serial MRIs.
So a quick comment. Thank you for a very educational presentation. I learned a couple of months ago, dealing with one of these patients, that you can have checkpoint inhibitor therapy for a very extended period of time. This is not 4 cycles that are done in 3 months. You can be on checkpoint inhibitor therapy for years, right?
Lifetime.
Right. So it's so we had this patient who was 67 years old with multiple risk factors for coronary artery disease on checkpoint inhibitors, and came in with newly diagnosed heart failure, and everybody literally freaked out. They got really nervous about it. They wanted an MRI, they wanted a biopsy, and we ended up catting the patient, who ended up having 3-vessel significant coronary artery disease. So the question becomes, how do you tease out in patients who have potential 2 etiologies for a newly diagnosed heart failure with positive troponins and some conduction abnormalities? And when do you aggressively start treating checkpoint inhibitor myocarditis if you have concomitant coronary artery disease?
Yeah, I mean, that's a great point. I think you need to exclude other etiologies, and I would take these patients pretty rapidly to the cath lab to exclude ACS as the etiology, and if that's absent, you should be able to do that within hours, right? And in the absence of diagnosing ACS, and start therapy.
So with your help, we're going to update our SCAI oncocardiology guidelines. So we wrote the SCAI expert consensus almost 7 years ago, where we showed the value of early invasive strategy in cancer patient population. And we tell our fellows and everything, when you have a cancer patient coming to the EC with shortness of breath, so not chest pain. So the cancer patients come as ACS with shortness of breath and not chest pain. Cardiac biomarkers are positive in the context of sepsis, ICM myocarditis, ACS, and everything. We tell them, remember TAMPA. So TAMPA comes from T is Takotsubo, or tumor involvement of the myocardium. A is amyloid. M is myocarditis. P is pericarditis. And the last one is ACS, because we never forget ACS, because you always look at that. So the patients come to the ER, we get them on the cath lab table, and where Cangalore really it's very, very helpful. We give them Cangalore until we figure out what's happening. If they need a biopsy, then we do the biopsy. If they need fixing the stent, so we do the stents. If it's Takotsubo, we're happy, and we call it quits, and we're happy. We got really good results. And a good amount of them actually is interesting and humbling to us are amyloids, which not right now we're seeing them, because that's negative, that's negative, that's negative. So we end by getting a lot more amyloids than we ever got before.
Thank you for your comment.
Appreciate it.
Wonderful. Thank you.
Yeah, we're going to end. Thank you very much, Michael.